Welcome to this explainer. We usually think the hardest part of a medical crisis is, well, the crisis itself. But today we're focusing squarely on the dangerous reality of recovery. Sometimes pulling a patient back from the brink of a massive physiological deficit is where the real danger begins. We tend to relax once the numbers stabilize, right? But as we're going to see, the human body's compensatory mechanisms, they can be incredibly unforgiving.
So what actually happens when the cure becomes a crisis? Let's dive into this medical mystery. We're going to look at how correcting a severe deficit can literally and silently spiral into a catastrophic systemic overflow. It's a phenomenon that lurks right in the shadows of successful surgeries, where the very treatments keeping a patient alive can suddenly turn into agents of massive organ damage. To wrap our heads around this, we really need to look at one of the most tightly regulated elements in the human body, calcium.
All right, let's jump right into Section 1, the clinical calcium puzzle. Picture this. We've got a 62-year-old guy with end-stage renal disease, and he's on hemodialysis. He recently had a subtotal parathyroidectomy. By post-op day 5, his severe hungry bone syndrome had finally stabilized thanks to a heavy IV calcium infusion. His labs, they looked fantastic. So his care team confidently unplugs the IV and transitions him to oral calcium carbonate and calcitriol. Boom, he goes home. But 3 weeks later, he's back in the ER, and he's not suffering from low calcium anymore. Actually, he's got unremitting abdominal pain, vomiting, and a dangerously high serum calcium of 12.8. And it gets worse. A renal ultrasound shows a massive, brand-new 8mm staghorn calcium completely obstructing his remaining kidney tissue. So what on earth went wrong here? Well, the doctors treated his hungry bones for sure, but they forgot one crucial thing. Once the skeleton is full, the shift from a mineral vacuum to a systemic overflow happens silently, rapidly, and destructively.
Which brings us to Section 2. The central bank of calcium.
To figure out what went sideways with our patient, we first have to understand normal calcium regulation. Think of it like a highly sophisticated national economy. Calcium isn't just the structural mortar for our bones, it's literally the vital electric currency for our neuromuscular transmission and cardiac stability. In this physiological economy, parathyroid hormone, or PTH, is the central bank chairman. Our bones? That's the central vault, hoarding about 99% of the wealth. The bloodstream is the active liquid market. It holds less than 1%, but it drives all the daily transactions. When the liquid market runs low, Chairman PTH prints orders to withdraw funds from the bone vault, tax the kidneys a bit less by reabsorbing calcium, and boost imports from the gut using calcitriol, which is the active form of vitamin D. And if things get too hot, calcitonin acts as the physiological brake to cool serum calcium back down.
Now, the chairman doesn't just guess. These decisions are entirely dictated by the calcium sensing receptor, or CAS. This is a fascinating G-protein-coupled receptor sitting right on the parathyroid chief cells. Its whole job is to detect microscopic fluctuations in serum calcium. If calcium is high, it binds to the receptor and basically tells PTH to hold off. But the exact second ionized calcium drops, the receptor remains unbound, and boom, it rapidly triggers the release of preformed PTH into the bloodstream in a matter of seconds.
Now, this brings up a really critical question about how PTH interacts with the kidneys. Why does PTH waste phosphate in the urine while it so carefully conserves calcium? Well, it comes down to basic chemistry and, honestly, self-preservation. See, if PTH allowed both calcium and phosphate to rise at the same time in the blood, they would exceed their solubility product. They'd essentially precipitate out as solid calcium phosphate crystals straight into your soft tissues, causing massive organ damage. So deliberately wasting phosphate is the body's clever way of keeping calcium safely free and ionized in the plasma.
Okay, moving on to Section 3, the skeletal battery vacuum. Let's go back to our patient for a second. After his surgery, he developed what we call hungry bone syndrome. By taking out his overactive parathyroid glands, that sudden massive drop in PTH transformed his entire skeleton into a giant, completely depleted lithium-ion battery. We manage this intense skeletal avidity in two distinct phases. First up is the acute IV fast charge. This high-voltage phase is absolutely crucial right after surgery. It bypasses the gut and maintains immediate neuromuscular stability, basically preventing terrifying things like laryngospasm or total cardiovascular collapse. But obviously, you can't keep a patient on an IV forever, so we switch to the oral trickle charge. This relies on oral calcium and calcitriol to provide a nice, steady current to slowly fill up those depleted bone cells over weeks or even months.
And here is exactly where the medical puzzle unravels. Let's look at Section 4, the dangerous overflow. Managing this oral transition is a crazy, precarious balancing act. Yes, the bones are absorbing calcium at an incredible rate, but eventually, they get full. And leaving the charger on maximum power once the battery hits 100%, that is incredibly dangerous. The absolute crucial point here is this number, 55. If the systemic calcium phosphate solubility product, which remember is your serum calcium multiplied by your serum phosphate, if that exceeds 55 milligrams squared per deciliter squared, you've got a chemical disaster on your hands. The extracellular fluid reaches chemical saturation. At this threshold, those ions spontaneously organize into solid microcrystalline structures. They precipitate destructively into soft tissues, blood vessels, and, just like our patient unfortunately experienced, the kidneys. To put that into perspective, according to the EVOLVE trial, crossing this threshold correlates with a massive 44% increase in cardiovascular calcification and stroke. It's a real game changer.
So, how do we actually know when the battery is full? The skeleton literally tells us. It signals saturation when mechanical strain changes in the bone canaliculae. As those hydroxyapatite crystals fill the spaces, they trigger the osteocytes, which are essentially the bone's mechanical sensors, to secrete sclerostin and FGF23. Sclerostin then binds to LRP5 and 6 receptors and abruptly shuts off the WNT beta-catenin pathway. At this exact molecular moment, the skeletal vacuum just turns off. Bam! Done. If you don't immediately reduce the oral calcium and calcitriol doses right then, all that excess current just spills right over into the systemic circulation.
Now, to avoid this overflow, you can't just wave a hand and say, take some calcium. You have to pick the right supplement for the gut-specific biophysics. Calcium carbonate yields about 40% elemental calcium, but it needs a highly acidic stomach. We're talking a pH under 2.0, just to break its bonds. Calcium citrate, on the other hand, yields only 21%, which means taking more pills, but it's completely pH independent. So think about it. If you give calcium carbonate to an elderly patient who's taking an acid-reducing PPI like omeprazole, their gastric pH is going to be way too high. That pill is just going to pass right through them unionized, literally like a piece of chalk, and it completely fails to treat those hungry bones.
This brings us to our final act, Section 5, a safe recovery protocol. To successfully navigate this super treacherous phase without completely blowing the body's circuitry, we really have to abandon static prescriptions and rely on rigid, dynamic clinical protocols. This structured approach is beautifully mapped out in the ambulatory taper protocol. You move from inpatient stabilized weaning to a really strict weeks 1 and 2 titration. That's followed by the absolutely critical week 3 and 4 calcitriol taper before finally landing on a month 2 and 3 maintenance baseline. And applying a kinetic protocol like this, it isn't just theory. The Oxford postoperative endocrine taper study showed that adjusting treatments dynamically reduces late rebound hypercalcemia events by a staggering 82%. 82%! And it significantly lowers post-discharge kidney stones too.
So the million-dollar question, how do you know exactly when to trigger that taper during weeks 3 and 4? Well, you track total alkaline phosphatase, or ALP. When you see a downward trend, specifically a drop of about 20 to 30% from its postoperative peak, that right there is your exact kinetic signal. It tells you osteoblastic bone synthesis is finally slowing down. The skeletal battery is full. That is your undeniable cue to safely and immediately taper down the calcitriol dose.
And we absolutely have to remember this incredible piece of bedside wisdom regarding the 24-hour urine trap. As the senior attending's ward note reminds us, do not rely on random spot checks. They create a total fractional excretion illusion. You need a true 24-hour urinary calcium collection. If that number exceeds 300 milligrams per day, the renal tubules have hit their physiological maximum, period. Even if the serum calcium looks completely normal on a blood test, that high urinary volume will silently form calcium crystals in the renal pyramids, causing irreversible nephrocalcinosis. You literally must reduce the oral intake immediately.
The dangerous reality of recovery is that it's never a passive phase. It's an active, constantly evolving physiological state. True mastery of this physiology requires constant, dynamic vigilance. So as we wrap up this explainer, I want to leave you with this question to really chew on. As you guide a patient out of the woods and their vital signs finally stabilize, are you paying close enough attention to safely unplug the charger? Thanks for joining me, and always keep questioning the numbers behind the recovery.